say, how do you as doctors know, or the oncologists know, that the chemo is working? So now you take off with your whatever.
So we do chemotherapy in two settings. The one is what we call a neoadjuvant setting. That means we do chemotherapy before we start with your surgery. And obviously, if you have a 5 centimeter cancer, or you have a cancer that's all over your body or whatever, and you give the patient chemotherapy and all of that shrink away, then you know the chemo is working. If your doctor decided to cut out that 5 centimeter cancer, and there's nothing left, and he gave you chemotherapy, there's no way of knowing whether that chemo is actually working or not. You give a standard recipe for that patient, and you sort of hoping that it will help. So and I think that is a change in breast cancer. If I give talks, if I give advice to people, the one thing I always say is, if you make a decision that the patient needs to have chemotherapy, then that chemotherapy should preferably be given up front. So if you already know you have a big tumor and you already know you have big lymph nodes, that patient should not have surgery. So, I would go as far as say no patient who has clinically big, palpable lymph nodes, none of them should have surgery up front. They should all have treatment to shrink the cancer first. It can be chemo or it can be anti-estrogen treatment, but you should have treatment first. You should not just be jumped in with surgery.